Hi friends, welcome to PharmaGrid. So today we are going to discuss about liver function test. Mainly we will see what are the common tests that comes under liver function test and what are their significance and how can we interpret the test results. So if you find these videos useful, please support me. Your support means a lot, that will give me motivation to make more and more videos. Okay, so let's begin with today's video. So, liver function tests are biochemical investigations to assess the capacity of liver to carry out any of the functions it performs. Or in simpler terms, we can say that LFTs or liver function tests are a group of blood tests that measure enzymes, proteins, and bilirubin produced or processed by the liver. They are used to screen for infections, diagnose diseases like hepatitis, monitor medication side effects, and assess the severity of existing liver damage. This LFT will help to detect the abnormalities and the extent of liver damage. As you all know, the liver plays several important roles in our body. The two most important functions of the liver are its synthetic function and excretory function. The synthetic capabilities of the liver are estimated by serum levels of the proteins synthesized and released by the liver. The two most important such proteins are albumin and clotting factors. So, in a person with liver disease, if the synthetic function of liver is compromised, it will result in two important problems. First one is low serum albumin causes bilateral pitting type pedal edema, ascites or anasarca. Second one is impaired synthesis of clotting factors results in prolongation of the prothrombin time, which may cause spontaneous bleeding such as ecchymosis. So these all are the things that happen when the synthetic function of the liver is compromised. First one, there will be low serum albumin which results in pitting type pedal edema, ascites or anasarca. Second one is impaired synthesis of clotting factors that results in the prolongation of prothrombin time, which may lead to bleeding such as ecchymosis. Now moving on to the excretory function. The liver normally excretes bilirubin, which is a waste product of hemoglobin metabolism. Bilirubin is normally excreted in the bile and expelled in the feces. In the presence of impaired excretory function, bilirubin starts accumulating in the blood and manifests as jaundice or yellow discoloration of the eyes and urine. Now let's see what are the commonly used liver function tests. They can be mainly categorized into three types, that is liver enzyme test, liver protein test and bilirubin test. Liver enzyme tests include alanine transaminase, that is ALT, aspartate transaminase, that is AST, alkaline phosphatase, that is ALP, and gamma glutamyl transpeptidase, that is GGT. Then liver protein tests include total protein, albumin, globulin, prothrombin, and then bilirubin test. So here you can see an overview of commonly used liver function tests, their normal value and their purpose. So the reference ranges for these tests may vary slightly between laboratories and populations. First, we'll discuss in detail about the liver enzyme test. So the liver function test include estimation of the serum levels of four important enzymes in the liver. An increase in the serum levels of these enzymes indicates liver injury. Each of these enzymes is located in specific areas within the hepatocytes and cholangiocytes. So here you can see the liver cell and the enzymes and their location. So the first one is alanine aminotransferase, also known as SGPT. It is located in the cytoplasm. Then aspartate aminotransferase, also known as SGOT or AST. Location is cytoplasm and mitochondria. Then alkaline phosphatase in canaliculi, gamma glutamyl transpeptidase also in canaliculi, and LDH, that is lactate dehydrogenase in mitochondria. Then here you can see what happens in case of liver injury. This liver injury led to the release of liver enzymes. So in case of liver injury or death of liver cells, there will be release of ALT and AST from hepatocyte cytoplasm. Then in case of biliary obstruction, there will be release of alkaline phosphatase and GGT from canaliculi. In case of long-term liver injury, AST levels will be more than ALT. And also in case of alcohol-induced liver injury, this alcohol specifically damages mitochondria. So in such conditions, AST level will be higher than the ALT levels. Serum ALT, which was earlier known as SGPT, and serum AST, which was earlier known as SGOT, are released from the hepatocytes into the circulation after hepatocyte injury or death. Then the serum alkaline phosphatase and GGT are located in the cholangiocytes and represent their injury or death. These cholangiocytes are injured in biliary tract diseases such as cholangitis, biliary obstruction, etc. So as we have seen, this ALT and AST are two separate enzymes which are used as markers of liver injury. It is common to see them as synonymous with each other. But these two enzymes differ markedly from each other and have their own clinical significance. ALT is primarily located in the liver and hence it is a more specific enzyme for liver injury than AST, which is more widely distributed in the body. Okay, so note this. This ALT is primarily located in the liver and it is a more specific enzyme for liver injury than AST. Then the serum AST levels are frequently elevated in the presence of heart diseases such as ischemic heart disease, hemolysis, and muscle injury. Further, ALT is located in the cytoplasm of the hepatocytes and hence is released by minor injury. This makes ALT a sensitive marker of liver injury. Now, regarding AST, it is primarily located inside the mitochondria and is also found in the cytoplasm of the hepatocyte in a relatively low concentration. This AST is released from the hepatocyte after more severe injury, in particular, after injury with an agent that causes injury to the mitochondria such as alcohol. Hence, AST is a less sensitive and less specific marker of liver injury than ALT. AST is more elevated than ALT in alcohol-induced liver injury. One important aspect is that ALT has a longer half-life than AST. Hence, the serum ALT level takes a longer time to normalize than the AST after the injury has subsided. So, as a summary, we can say that this ALT is indicator of liver injury and AST is indicative of fibrosis. So, ALT is used in hepatitis B management while AST is used in hepatitis C management. So in this slide, you can see the major differences between this aminotransferase, ALT as well as AST, that is alanine aminotransferase and aspartate aminotransferase. Based on the organ localization, this ALT mainly in the liver and kidney, whereas AST in the liver, heart, muscle, and red blood cells. Then coming to the organ specificity, as we have already discussed, that this ALT is a more specific marker for liver disease, and AST is less specific for liver disease. Then coming to subcellular location, ALT mainly located within the cytoplasm. So in case of minor injury, there will be easy leakage of ALT. Whereas AST majority, that is 80% is located within the mitochondria and only 20% in cytoplasm. And these AST levels are higher in case of alcohol induced liver injury. Then half-life. Coming to the half-life, ALT has got a longer half-life compared to AST. So we have already discussed about the liver enzyme test. Now moving on to liver protein test. So, total protein measures the amount of protein in your blood. The two main proteins found in the blood are globulins and albumin. This globulin is a protein made in your liver and helps the immune system fight infections. Low globulin levels can be a sign of liver damage or other conditions. Then albumin is another protein made in your liver. An albumin test measures how well your liver is making the proteins that your body needs. Low albumin levels can be a sign of liver damage. Then prothrombin is a protein made in your liver and helps with clotting blood. A prothrombin time test measures how much time it takes for your blood to clot. A high prothrombin time can be a sign of liver damage. Now we'll discuss in detail about the serum albumin test. So as we have already seen, this albumin is the main body protein that maintains the oncotic pressure inside the circulatory system. It is synthesized in the liver and has a half-life of 21 days. This long half-life of albumin helps us use it as a marker to differentiate between acute and chronic liver injuries. In acute liver injuries such as acute viral hepatitis, serum albumin levels remain normal. In contrast, in the presence of a long-standing chronic injury such as liver cirrhosis, the serum albumin is reduced. So note the point that this serum albumin levels helps to differentiate between acute and chronic liver injuries. So in acute liver injuries, serum albumin levels remain normal, whereas in case of chronic injuries such as liver cirrhosis, the serum albumin level is reduced. Serum albumin may also be reduced because of excessive loss of albumin, such as in patients with renal disease in whom protein is lost in the urine. Now let's see about prothrombin time, which is commonly known as PTINR. Is a composite marker of serum levels of various coagulation factors synthesized in the liver. This reflects the time that in seconds taken for blood to clot. In the presence of significant liver disease, the synthetic functions of the liver are compromised and clotting factor levels are reduced in the serum. Reduction in clotting factors leads to prolongation of the PTINR. Mild liver injury does not cause prothrombin time prolongation. Only if a severe injury leads to liver failure is the prothrombin time prolonged. Hence, PT prolongation is a marker of liver failure. So here you can see a summarization of PT-INR test. That is, it is a laboratory test that measures some aspects of blood coagulation. It depends upon the concentration of clotting factors in the blood, and this PT-INR value is prolonged. The prolonged PT-INR value indicates reduced liver function, and it is a specific marker of liver failure, not a marker of liver injury. So it's useful for monitoring degree of liver dysfunction. Now we'll see about the bilirubin test, which is one of the most important tests that comes under LFT. So before that, we should first understand about the bilirubin metabolism. It can be summarized into four steps. The first one is breakdown. That is, the aged red blood cells are destroyed in the spleen and liver. The hemoglobin breaks down into heme, which becomes unconjugated bilirubin. Next step is transport. Because this unconjugated bilirubin is water insoluble, it must bind to albumin to travel safely through the bloodstream into the liver. Next step is processing. In the liver, the enzyme UGT, that is UDP glucuronide transferase, adds sugar molecules to the bilirubin, converting it into water-soluble conjugated bilirubin. Then the last step is excretion. This conjugated bilirubin moves into the intestine via bile. The gut bacteria convert it into urobilinogen, which is then either excreted in feces, which gives it a brown color, or processed through the kidneys and excreted in urine. It is very important to understand the difference between unconjugated and conjugated bilirubin. Unconjugated bilirubin, also known as indirect bilirubin, it is lipid soluble, toxic at high levels, it's bound to albumin, cannot be excreted by the kidneys, so it does not appear in urine. Then conjugated bilirubin, also known as direct bilirubin, it is water soluble, non-toxic, moves freely in bile, can be excreted in urine. And this causes dark urine if liver or bile systems are blocked. Serum bilirubin. As we have already seen, this bilirubin is a breakdown product of hemoglobin and it is a predominant pigment in bile. Effective bilirubin conjugation and excretion depend on hepatobiliary function and on the rate of RBC turnover. Serum bilirubin levels are reported as total bilirubin. Total bilirubin means it's a combination of conjugated and unconjugated bilirubin, and as direct bilirubin, that is conjugated only. Bilirubin is released by hemoglobin breakdown and is bound to albumin as water insoluble indirect bilirubin, that is unconjugated bilirubin, which is not filtered by the glomerulus. Unconjugated bilirubin travels to the liver where it is separated from albumin, conjugated with diglucuronide, and then actively secreted into the bile as conjugated bilirubin, which is also known as direct bilirubin, which is filtered by the glomerulus, which we have already discussed in the bilirubin metabolism. Normal values of total serum bilirubin are 0.121 milligram per deciliter of direct bilirubin is 0.0 to 0.2 milligram per deciliter, which is equivalent to 0 to 4 millimole per liter. An increase in serum bilirubin results in jaundice from bilirubin deposition in the tissues. There are three major causes of increased serum bilirubin. First one is hemolysis, second one is biliary obstruction, and the third one is liver cell necrosis. Hemolysis increases total bilirubin. Direct bilirubin, that is conjugated, is usually normal or slightly increased. Urine color is normal and no bilirubin is found in the urine. Then in case of biliary obstruction, which may be intrahepatic as with a chlorpromazine reaction, or extrahepatic as with a biliary stone. It increases total bilirubin and direct bilirubin. Then intrahepatic cholestasis, example from chlorpromazine, may increase direct bilirubin as well. Urine color is dark and bilirubin is present in the urine. Next is liver cell necrosis, as occurs in viral hepatitis, may cause an increase in both direct bilirubin because inflammation causes some bile sinusoid blockage, and indirect bilirubin because the liver's ability to conjugate is altered. Urine color is dark and bilirubin is present in the urine. Increased red blood cell destruction, that is hemolysis, results in increased unconjugated bilirubin in the blood. That is excessive destruction called hemolysis of red blood cells, regardless of its cause, will result in hemolytic or unconjugated jaundice. Hemolytic jaundice is commonly seen in patients with hemoglobinopathy such as sickle cell anemia, thalassemia, etc. Most of the hemolysis in our body takes place in the spleen, and hence majority of the patients with hemolytic jaundice also have splenic enlargement. In most patients, an enlarged spleen is firm and non-tender. In addition, the majority of patients with hemolysis will also have anemia or low hemoglobin. Poor function of liver cells will result in increased conjugated bilirubin in blood. The liver is involved in two steps of bilirubin metabolism, that is conjugation of unconjugated bilirubin and excretion of conjugated bilirubin. Injuries or diseases affecting the hepatocytes result in a reduction of both of these liver functions, but the excretory function is more affected than the conjugatory function. In the presence of liver diseases such as viral hepatitis or liver cirrhosis, conjugated bilirubin is not completely excreted in the bile but is released into the circulation, which results in a mixed pattern of jaundice with a predominance of conjugated bilirubin. Obstruction of the biliary tree causes increased conjugated bilirubin in the blood. Several diseases could cause obstruction of the biliary tract. These diseases neither affect the conjugation of bilirubin in the liver nor affect the excretion of conjugated bilirubin from the liver into the bile, but they stop the flow of bile into the biliary tree. Because of excessive accumulation, bile is refluxed from the liver into the circulation and results in conjugated hyperbilirubinemia. The most common causes of biliary tract obstruction are gallstone disease, carcinoma of the gallbladder, cholangiocarcinoma, etc. So in this slide, you can see an approach to a patient with raised bilirubin, that is jaundice. So in a person with jaundice, the first thing we need to see is the proportions of conjugated and unconjugated bilirubin. The presence of less than 20% unconjugated bilirubin fraction indicates an underlying hemolytic disorder. On the other hand, if the fraction of conjugated bilirubin is more than 50%, it is known as conjugated hyperbilirubinemia and indicates the presence of liver or hepatobiliary disease. Once conjugated hyperbilirubinemia has been identified, we need to do an ultrasound abdomen, that is USG. The radiologist will be informed about what we need to see in the USG. The USG would look for evidence of the following, that is biliary obstruction such as dilatation of the biliary tract, gallbladder mass or any other mass in the liver, then evidence of chronic liver disease such as liver size, smooth or nodular liver surface, then regular or irregular liver margin, then portal vein dilatation, then spleen size, presence of venous collaterals at the splenic hilum and around the portal vein, presence of ascites, etc. A good ultrasound examination can reliably differentiate between liver disease and biliary tract disease as a cause for conjugated hyperbilirubinemia. The next step after the possibility of biliary obstruction has been excluded is to look into the pattern of liver enzyme elevation, which helps us to identify the possible cause of the liver disease. There are three patterns of liver injury: hepatocellular, cholestatic, and mixed patterns. In the hepatocellular pattern of liver injury, there is marked elevation of ALT and AST. In cholestatic liver injury, there is marked elevation of alkaline phosphatase and GGT. Patients with a mixed pattern have a variable combination of liver enzyme elevation. So in this slide, you can see the summary of liver function test and what are the key parameters and their significance. Mainly this ALT, that is alanine aminotransferase, AST, aspartate aminotransferase, ALP, alkaline phosphatase, then bilirubin, total protein and albumin, then GGT, gamma glutamyl transferase. So I hope this topic is clear for everyone. If you have any doubts, you can mention in the comment section. Thank you for watching. Have a pleasant day.